Mr. Chairman, ladies and gentlemen, at first I want to thank the Romanian Society for Cardiovascular Surgery for the invitation to this meeting and to get the chance and opportunity to lecture on a special form of myocardial protection. The title is Indications and Advantages. Thank you. Advantages of HDK solution in cardiac surgery. Okay. In cardiac surgery, there is a cardioplegic paradigm, and this paradigm says you have to cardioplegically reperfuse every 10, 20, 30, 40 minutes. And I may ask, why is it so? Because cardioplegic redosing has practical disadvantages. If you prefer the integrate perfusion, for example, you have in minimally invasive cardiac surgery, you have to interrupt the operative procedures, especially in case of Bentel procedure or the David procedure, or in the arterial switch operation, which we do not forget. You have at some intervals, you have unstable coronary ostia. Especially for mitral valve repair, you have to replace the retractors. And we should not forget the neonates. If you prefer retrograde perfusion, what Dr. Backpack always prefers, yes, there's a risk of sinus injury, the risk of malpositioning of the catheter, but, and that is, to my opinion, the most important or most significant argument against, only 70% of the coronary venous blood drains into the sinus. There was a wonderful study in patients without coronary heart disease, and they compared anti and retrograde perfusion. And the parameter they looked for was the video intensity. And you see, there is no difference between the free wall, the septum, and the right ventricular free wall. But if we now compare this with retrograde perfusion, you see there is a significant reduction of the perfusion of the right ventricle. So that means the retrograde perfusion by retrograde cardioplegic solution bears the risk of an inappropriate protection of the right ventricle. So what is the optimum? The optimum is one single integrate perfusion and nothing else. But the question again rises, why is it so that we have to reperfuse? Because we have a problem, a physiological problem, and that says, during anaerobic glycolysis, lactate will be produced, and this will lead to myocardial acidosis. Unfortunately, if you will not interrupt this acidosis, this production of acidosis, then this anaerobic glycolysis will be inhibited. That says, or with other words, the heart is killing itself. And this leads to a cell death. Now, what methods do we have to reduce myocardial acidosis? Either continuous perfusion, very seldom done today. Most of the surgeons replete, as I already mentioned, or another opportunity is to use a highly extracellular buffering. When Bertrand and we started, he took a sheet of paper, and the last word of this sheet of paper is this one: In German, that is translated amino acid buffer. So I may say this is the document of birth for this idea to use a buffered solution. The solution I speak about today is this, I call it always HDK solution. You see it is a low sodium solution, a calcium poor solution, potassium enriched, magnesium enriched, but the most important parameter is histidine. It's an amino acid buffer at a very high concentration. Tryptophan and ketoglutarate and mannitol. Histidine and mannitol are the best free radical scavengers we know. Therefore, we have never been faced with the problem of ischemia reperfusion injury after declamping of the aorta. Because the histidine concentration is so high at that moment that all these free radicals will be captured. The other biochemical properties of the solution are the following. It's an excellent biotolerability, a sufficient solubility, high buffer capacity, acceptable pK value. We cannot influence this pK value. It's a natural constant. And most important part is this, the temperature dependency of the solution's pH. 7.4 at 5 degrees, 7.1 at 25, and 6.8 at 35 degrees. And this is very important for 3 groups in the OR, the anesthesiologists, the surgeons, and the perfusionists. Because, I will give you an example. If we have a patient at the extracorporeal volume plus the intravascular volume of 5.5 liters. And we will add 1.8 liter of HDK volume to the total circuit. The pH of the extracorporeal circulation is 7.4, but the HDK pH at 34 degrees is 6.9. And if we now calculate what is the appropriate pH, the appropriate pH is less than 7.3 under these conditions. So the pH will change, the systemic pH will change only due to physicochemical reasons, nothing to do with respiration, nothing to do with metabolism or a special other problems which might occur during the operation. Only due to this. This normalizes after 20, 30 minutes. One thing is very often underestimated, and that is the viscosity. And please look at this. The HDK solution has the same viscosity as water. If you use, for example, the Buckbag method, the 4-to-1 blood cardioplegia, it's by far higher viscosity. And this is important in severe coronary heart disease, in patients with left ventricular hypertrophy, and you see the question mark perhaps in neonates. The basic elements of myocardial protection are the cardioplegic solution, I spoke about this, and the cardioplegic delivery. Most probably you might be a little bit astonished. Why cardioplegic delivery? I will show you some very interesting arguments. This is the cardioplegic method. We often speak about cardioplegia. Cardioplegia consists always on both solution and delivery. And we have analyzed the O2 consumption of humans during the cardioplegic perfusion, and you see we could reduce the O2 consumption from about 3 ml to 1 ml. Temperature equilibration happens within 2 minutes, 3 minutes. So only the influence of the composition, or the influence of the solution will reduce this O2 consumption. The question rises, is it the same with symptomatic solution? And I say, look at this. Again, in patients, we measured the O2 consumption, and after 3 minutes, the same amount of oxygen consumption occurred. But at that time, Dr. Brambridge recommended only a 3-minute perfusion. Why, ladies and gentlemen, is it necessary to reduce the O2 consumption as much as possible? Because the lower the O2 consumption is, the higher is the creatine phosphate content. We may argue only by a prolongation of the cardioplegic delivery, you will improve the energetical status of the myocardium. I can only speculate whether it might be of clinical interest, of clinical significance. I do not know, but this is a theoretical or scientific aspect. I personally have looked for another parameter. And I choose harmonic imaging during cardioplegia. And you see, even after, this is a lady, 64 years old, severest hypertrophy of the left ventricle due to a mitral valve stenosis. And even after 6 minutes of perfusion, there are some areas that are not equilibrated with the solution. I tell you, we came off bypass without problems. But this might be a reason why sometimes the surgeon has done a perfect operation, but you have problems to come off bypass because of an inadequate myocardial protection. What the consequence is, equilibration processes are volume, but mostly time related. We have analyzed whether it is okay to administer the solution within 2 or 3 minutes. The results were inferior. So this is a further argument why it is a time-related process. What we do is we only use a simple perfusion set, a 9 French inch, a vent cannula, this is the 3 6-inch perfusion line and nothing else, and it's a 3-way stop. We cross-clamp the aorta, suck as much as possible till the venting line collapsed, and then we switch the 3-way stop and starts with the hydrostatic or perfusion, gravity perfusion. The application guidelines are the following. We always prefer the antegrade perfusion, either venous cannulation 2-stage or the double venous. Perfusion volume, this is the amount in adults, amount in pediatrics, and amount in transplantation. Perfusion time 6 to 8 minutes in the adults, 4 to 6 in the babies, and 10 minutes in transplantation. This is important. The perfusion temperature plays a minor role, 6 to 10 degrees. I have administered the solution even at 20 degrees of centigrade, and it works as well. But in transplantation, it should be less than 5 degrees. But big advantage, only 1 single initial perfusion and no mandatory replegia up to 3 hours of cardiac arrest. Nothing else. Coming back to reperfusion. Cardioplegic reperfusion. There was a wonderful study from Sava in near and immature hearts. And look at this. Single perfusion is by far superior than replete every 20 minutes. Nobody from us would have expected this. And there's a study from Korea. And they compared famous Del Nido solution with HDK solution in rats. Ischemia 2 hours, repletes every 40 minutes with HDK, and no repletes. And the parameter they looked for was mitochondrial scoring, and that is the result. By far superior results if there was no repletes in the neonatal, in the rat hearts. So what are the indications? The indications, at first, pediatric cardiac surgery, valve surgery plus minus CABG, aortic surgery, the robotic or minimal invasive surgery, redo surgery, and transplantation. And the surgery with the trainees, I always joke and say, HDK solution protects the myocardium of the patient and the coronaries of the surgeon if they do the surgery with the trainees. The cabbage, that isn't an indication. You can use it, but today the surgeons are so fast, it makes no sense to applicate for a long time. And so the biggest advantage is not present in cabbage. Some data, clinical data, from Russia, a wonderful study that has been published last year. Babies, newborns, 7 hours of age, HDK solution, ischemia lasted for a little bit more than 1 hour, and they looked for the lactate level after declamping or after the operation, and look, after about 10 to 12 hours, there is a normalization of the lactate level. Another study comes from Beijing. They compared St. Thomas's solution versus HDK solution in babies. And you see, they reperfused every 30 minutes and no reperfusion, almost 3 hours, more than 3 hours of a rest. And they looked for mortality rate was lower in the HDK group, loss of CK, that was the parameter for evaluation of myocardial injury at the first and second day, was lower in the HDK group. A study from Bologna, and they looked for TGA, transposition grade arteries, HDK solution, no cardioplegic reperfusion, 95 minutes average, and the troponin I loss was the highest after 6 hours, but the amount was very low. They could demonstrate that they saved time for cross-clamping because the time for enduring in the crystalloid group versus the blood cardioplegic group was significantly lower in this group of 60 peds. Patients with aortic dissection, published in Italy last year. Oh. Sorry, something has grown. I apologize. Okay. Of our dissection, blood cardioplegia versus HDK, no redosing, but they reperfused every 20 to 30 minutes, cross-clamping time 150 minutes in each group. Troponin I loss was slightly inferior in the blood cardioplegic group. A study in Germany, from Leipzig, they looked for patients with mitral valve surgery, 2,700 patients, and the low output syndrome happens in 1.54%. Inotropes in 5 patients, intra-aortic balloon pump in 25, ECMO in 5, and the combination of ECMO and intra-aortic balloon pump was in 4 patients. The in-hospital mortality was only 1.5%. A comparative prospective study in Norway demonstrated in mitral valve surgery, blood cardioplegia versus HDK, that there were a significant higher incidence of ventricular fibrillation after declamping of the aorta in the HDK group. But if they compare, and that is very interesting from the scientific point, if they compare the loss of troponin T versus the cross-clamping time, there was a significant correlation in the HDK group, but there is no significant correlation in the blood cardioplegic group. Therefore, the FDA does not accept troponin as parameter for evaluation. Nobody knows the reason why is it so, as mentioned. We looked in patients, a study, one retrospective study in 128 patients. All patients were included in aortic valve replacement And we lost one patient due to an anaphylactic shock within 30 days. After 30 days, we lost 3 patients due to sepsis. And the parameters were, look, we had a perfusion time of 6.4 minutes. That was the amount of volume being applicated. Ischemia lasted for 80 minutes. This might demonstrate that we did not exclude anyone because the senior surgeons are by much faster, but the residents, they need more time to do the operation. And quadriplegic reperfusions were necessary in 14% due to ventricular activities. Another study, very interesting, in 2 ischemic periods in one operation. The first operation lasted for 74 minutes, and the second one after 1 hour, because some problems happened and nobody knows what to do, for 1 hour. We had a low output syndrome in the survivor group in 2 patients, and in the non-survivor group in 3 patients. The mortality rate were 11%. We looked for the metabolic recovery, and it is interesting that independent from the age, adults and pediatrics, after 10 to 15 minutes, there was a measurable recovery or reuptake of the lactate. Data from the ischemic time from transplantation, a little bit more than 3 hours, and early graft failure rate in 7%. All the other data are not due to the solution applied. This were from Oenhausen, about 1,300 patients. And finally, I will give you some interesting data. Look, we have looked for the energy. What happens if you apply to the canine heart different solutions? The unbuffered Brettschneider solution, St. Thomas and Kirkland solution. And the red dotted line demonstrates until the limit of 4 micromolar has been reached. There's no difference. There's really no difference among these solutions. But if you use the HDK solution, there is a highly significant difference. We could save energy. That is by far better. Why is it so necessary to save energy? Because, look, we have cross-clamped for different periods of ischemia, and the ATP content in the HDK group is by far superior than the ATP content in the other groups. Why is this necessary? Because during ischemia, creatine phosphate, ATP decrease, and myocardial edema increases. And if this ischemic lasted too long, but this is in a minute per hour, then a low output syndrome may happen. Ladies and gentlemen, there is another secondary low output syndrome, and this is the following reason. After declension of the aorta, creatine phosphate increases very fast. ATP remains at the same level, and then an intracellular edema occurs. And this intracellular edema leads to a decrease of the coronary flow, and a secondary ATP decrease occurs. And this also leads within hours to a low output. So I come to an end. Neonatal hearts and high cardiac morbidity due to increasing patient's age demand optimal intraoperative myocardial protection. Since energy content is not the main limiting factor of myocardial tolerance to ischemia, but the degree of acidification, quadriplegic reperfusions are a part and parcel of almost every quadriplegic method. Significant reduction of tissue acidosis is achievable by a highly buffered solution, so that plegic reperfusions become unnecessary. Highly buffered solution, by cramping time, myocardial temperature, and plegic redosing get less important, whereas histidine seems to be the only suitable buffer. Highly buffered solution make operations more simply and safer. And finally, Highly buffered solutions offer the opportunity of single application, dose application, even for long-lasting cross-clamping. That is for 3 hours. Thank you for your attention.
Thank you. Thank you very much, Professor Preusse, for this beautiful lecture. And now, paper is over for discussion. If there are one question, please.
Dear Professor, I have seen the action of this kind of cardioplegia in Italy. The real meaning was in cardiac surgery. I was very impressed. I just wanted to have one of the pictures you have shown from electron microscope.
Yeah.
You had three pictures from different types of cardioplegia. Could you show once again, because I didn't catch at what stage they were taken? I mean, at the end, at the top of the ischemia, or after reperfusion?
This was at the end of
Cross-clamping time?
Yeah, this is, so, okay.
Yes.
This is at the end. This is the end of ischemia. Yeah.
Not after the
Not
reperfusion.
I know. There is a recovery.
This is a trap.
You're right.
The main chains are developing after the reperfusion. As we discount all the let's say the reaction or this is a delaying of this moment.
I completely agree.
Yeah.
But if the status is poor before declamping, then afterwards it become much more inferior, much
Yeah,
worse.
you are right.
Yeah.
You are right.
But I completely agree. Yes.
Yeah. Thank you very much.
Thank you.
But
Thank you.
I
Thank you
tell
very
you
much.
honestly, I could not read this paper because it was in Korean language. The only thing, the pictures, the figures were in English. So
Thank you very much.